Siapa present nanti? Siapa present dulu? Semua dah ada dah? Semua dah ada dah? Berapa orang semua? Ni Y3 kan?
Yes.
Ha?
Yes, Doktor.
Y3, okey. Berapa orang semua Y3?
36.
36, Doktor.
36 namanya. First presenter siapa nama?
Sasha. Sasha
Sasha
Semini.
Nawi. Apa you present apa?
Bronchi asma.
Okey.
Okay.
Mungkin asma, okey ha. Boleh start dah.
Okay.
2.10.
Bismillahirrahmanirrahim. We will start with patient
Share tak?
today.
You punya slide mana? Ha? You dapat slide dia? Ha?
Ada sekejap.
You share screen tak?
Sekejap. Okay. So, a moment. Sekejap. Sekejap. Okay. So, we'll start with patient today with Kita Al-Fatihah.
Okay.
Right. Sorry, but this is
Ada sikit.
yeah.
Ha?
Alright.
Sasha tak
Alright.
dengar.
We will begin our seminar today.
Okay ha.
Okay. Well, Assalamualaikum warahmatullahi wabarakatuh. Good evening to everyone and welcome to seminar 10 respiratory seminar.
You semua dekat ni sekarang dekat ni. Berapa orang daripada dalam red zone?
14, Doktor.
Apa orang red zone? Daripada red zone daripada Selangor lah. Ha?
Ada juga yang dari Johor.
Johor mana red zone dia? JB.
Johor Baru.
JB red zone ya? Okay, continue ha. Boring betul tak? Boring kan? You okay ke? Macam ni belajar?
Risau kat Doktor.
Ha?
Tak okey.
Okay, duduk rumah makan jadi gemuk semua, tidur pukul 9, pukul 10 bangun. Okay lah start ha. Okay start. Mana ni? Share screen tak share screen pun Sasha?
Doktor, Syasha rasanya ada masalah internet.
Siapa punya? Sasha punya?
Syasha punya.
Ha?
Dia ada masalah internet.
Tidak orang lain present dulu. Kita Sasha, kita orang lain present dulu.
Okay, saya next presenter after Sasha. I will presenting about bronchiolitis.
Present lah.
Okay.
Sasha, you boleh ke you nak sort out you punya tu dulu?
Okay. No, it's just a technical error. I'm sorry.
Okay, sekarang. That's right. You boleh proceed ke you nak orang lain proceed dulu?
I can proceed insyaAllah.
Proceed lah.
Okay. Sekejap.
Cepatlah.
Alright. So, we'll continue.
Gelap oi. Okay ha.
Okay. So, Syasha Mimiti Maknawi, 1812-628, will be presenting on bronchial asthma. Okay, so basically this is my table of content for today. Right, so first of all, I'll talk about introductions. I'm going to do some introductions about the definitions and also the epidemiology of bronchial asthma. Okay, so basically the definition for bronchial asthma, asthma is defined as a chronic airway inflammations leading to increase in airway responsiveness that led to recurrent episodes of wheezing, breathlessness, chest tightness, and coughing, particularly at the night or early morning. It is often associated with widespread variable airflow obstructions that is often reversible, as the evidenced by more than 20% improvement in the peak expiratory flow rate or more than 12% improvement in the flow expiratory volume when in the response to administrations of bronchodilators. So this is a diagram to show the comparisons between the normal airway and the asthma airway, where we can see the lumen for the asthma airway is narrower compared to the lumen of the normal airway because of the hypersecretion of the mucus and the swollen of the airway lining. So for the epidemiology, asthma is the most common chronic disease among childhood, and in the world, there seems to be an increasing patterns of prevalence of asthma. Through a study by International Studies of Asthma and Allergy, the prevalence of asthma among the school-age children is around 10%, and the prevalence in Indonesia seems to be plateaued. Asthma is more common among the boys, and the prevalence is higher among the urban and inner city children, and also in the minority groups such as the blacks and also the Hispanic. Okay. 20% of the infants with the upper respiratory tract infections will have the wheezing, but then 60% of them will no longer have the wheezing by the age of 6. This is what we call as transient wheezers, where the symptoms will be
is this asthma?
Wheezing.
Huh?
Wheezing.
Yeah?
Wheezing that can be wheezing. It is about
Yeah, but is this asthma or not?
transient wheezers is not an asthma.
Then why you present those things?
No, but because it is also not associated, but it's
Ada ke diagnosis
it can be,
transient wheezer?
no.
Huh? There's no
There's no
diagnosis transient wheezer.
Yes.
Ada ke diagnosis
No,
transient
there's
wheezer?
no.
Huh?
There's no.
Yes, there's no
diagnosis of
diagnosis.
transient wheezer.
I don't like you. I like you to touch straight away asthma, yeah.
Alright.
Continue ha.
Alright, that's all. Okay. Next, moving on. Moving on to the type
Nanti bronchiolitis
of
nanti complicated juga sebab kalau you talking about transient wheezer, because transient wheezer ni bronchiolitis pun can cause wheeze. So continue ha, okay.
Right.
Type of.
Okay. The type of childhood asthma, where we have two types.
Recurrent wheezer is not asthma. Lagi apa lagi? What type?
And according to the Nelson textbook, the types of childhood asthma is the recurrent wheezing and also the chronic
There's
asthma.
no recurrent wheezer is not asthma. Asthma is chronic disease. Tak payah cakap chronic asthma lagi dah. Faham? Asthma itself is a chronic disease. Everybody knows it's asthma chronic disease. There's no such thing or type chronic asthma. Because asthma is chronic already. Apa lagi dia buat dia hantar? Nation tak betul lah lagi.
It's basically just to touch about.
Okay, bukan wheezer is not asthma. Faham? Bypass this one.
Alright.
Asthma is asthma. Bypass. This one boleh.
Moving on
Etiology.
to the etiology, the causes of the asthma, where we can divide it into two, intrinsic and also the extrinsic. Intrinsic also we can, intrinsic is the non-atopic asthma, where it is usually the genetic factors, like it is higher in the children with the first degree relative having asthma. And for extrinsic, usually it is the atopic asthma, where the atopic referring to individuals who have developed the IgE antibodies for some common allergens. Extrinsic factors, extrinsic causes can be the allergens, the environment, the infections, the weather, the exercises, any emotional expressions like laughing, crying, any food, occupations, or any pharmacological like the aspirin. We go a little bit more about the extrinsic factors, which the first one is the respiratory infections. The most common one is the viral infections, but it can be also by other infections like the fungi, bacteria, and also the parasite. For the allergens and irritants, for allergens we have, for example, we have the food, any house inhalants like the animal allergens, the mold, the dust mite, or the seasonal outdoor allergens like the pollen and the grass. For irritants, it is anything that can irritate our airway, like the tobacco smoke, the cold air, the chemicals, the perfumes, etc. Others are like the exercise, or known as exercise-induced asthma. It can be due to any vigorous physical activity or exercise that can cause bronchoconstrictions and causing asthma. And then we have the inflammatory conditions of the upper airway, like in the conditions of gastroesophageal reflux disease. And for nocturnal asthma, it can be due to allergen exposure, abnormalities of the CNS, and also posture-related irritations of the airway. Okay. For the pathophysiology of asthma, it is quite complicated, but to put it simple, any trigger factors like what I've mentioned before, the etiologies before, either it can be the genetic or the extrinsic factors, it can cause the inflammations to the airway. Therefore, these airway inflammations can cause hyperresponsiveness, and hyperresponsiveness of the airway leading to things like secretions of the mucus, airway muscle constrictions, and also swelling of the bronchial membrane. These conditions leading to narrowing of the breathing passages. Therefore, it will limit the airflow, causing the symptoms like wheezing, coughing, shortness of breath, and also tightness in the chest. This is another example for the pathophysiology where, for example, an allergen will be picked up by the dendritic cells, which then will present it to the CD4 plus T cells or the Th2 T helper 2 cells. Okay, T helper 2 cells will secrete cytokines such as interleukin 4, 5, and 13. For the interleukin 5, it can stimulate the productions of eosinophils. Therefore, eosinophils can produce cytokines and also the leukotrienes. And Th2 helper cells also can stimulate the productions of IgE from the plasma cells. And then this IgE can the mast cells and stimulate the mast cells to release granules such as the histamine, leukotrienes, and also the prostaglandin B2.
Betul?
Okay, after that, this can lead to another two series of events, which are the increase in the mucus secretions and also smooth muscles around the bronchioles to be spasm, and then it will lead to airway narrowing of the airway, and then patient will have difficulty to breathe. So that's all for pathophysiology. Moving on next to the clinical manifestations and the complications. Okay, typical symptoms for asthma will be the coughing, wheezing, chest tightness, and also the shortness of breath. But we can also ask patients about any history of atopy, such as eczema or dermatitis, allergic rhinitis, allergic conjunctivitis, urticaria, food or drug history, or any family history of atopy. Okay, wheezing is okay. But then, what is wheezing? Wheezing is a musical, high-pitched whistling sound that produced by an airflow turbulence. It can occur during exhalations, but wheezing is not a necessary diagnosis for asthma. Okay, there are three types of wheezing. There are the transient, early wheezing, accumulated, and also the atopic. Okay,
Lah. Kalau you kena kalau you kena apa tu, what happen if you kena heart attack, congenital heart disease, you have heart failure, the lung you penuh dengan air, you still got wheezing.
Yes.
Ni tak betul ni, mana yang ambil tak tahu ni. Okay, continue.
No, okay. So this is what wheezing sounds like.
You know, wheezing is a sign which indicate that there is a airway obstruction and the main cause of wheezing. Wheezing tak apalah, continue. You ambil mana ni? You ambil mana ni?
Daripada textbook, daripada Medscape, and also the pediatric protocol.
Yeah, tak ada betul ke tak ada benda tu. I know this not pediatric protocol. Wheezing type ni. Continue. Because the classification make you headache, you know. Wheezing is wheezing lah. Continue it's a sign. Okay, sign apa continue.
For the signs, during physical examinations, we can, for first physical examinations, we can do the inspections where it can be found that there is an altered in consciousness, respiratory distress, cyanosis, dry skin, eczema, decrease in the percentile weight and height, any Cushing features because of the prolonged usage of the steroid, hyperinflated chest, and also the Harrison sulcus. And then during the palpations, there will be carbon dioxide retention, decrease in the chest movement, and also decrease in the vocal frenzy, and also increase in the epididymis due to hyperinflated chest. During percussion, there will be a hyperresonance to the percussion, and lastly, during auscultations, there will be found there is a diminished air entry, vesicular breathing with a prolonged expiratory phase, and generalized expiratory rhonchi, and also crepitations in infants. And then for the complications, we have status asthmaticus. Status asthmaticus is an acute asthma attack that can be a life-threatening conditions and may need hospitalizations. And also other complications, we have the pneumonia, we have the respiratory failure, and also the atelectasis. Okay, for differential diagnosis and investigations. Okay, how to diagnose asthma in the children less than 5 years old? We can have the probability. We can know the probability of the asthma, either it is low, moderate, or high, by asking these four questions: the durations of the symptoms, the number of exacerbations or the number of attacks, any interval symptoms between the episodes, or any family history of asthma. From this, we can know that either it is the children will have a low or high probability to get to suffer from asthma. Other differential diagnosis, we have the vocal cord dysfunction, upper respiratory tract infections, cardiac failure, bronchiolitis, pneumonia, sinusitis, gastroesophageal reflux, chronic lung disease, and others. Okay, moving on to the investigations. First investigations can be done is the lung function test, where the first test that can be conducted is the spirometry test. It is a diagnostic test. It is to monitor the response to the treatment, assessing the degree of reversibility, and also measure the severity of the asthma exacerbation. But then this test should be repeated for 3 times to get the validity. And in the case of obstructive defect, will present with a normal forced vital capacity, reduced in the FEV1, reduced in FEV1 to FVC ratio by less than 0.8, and also reduced in FEF for more than 25 to 75% of the FVC. Okay, next lung function test is the peak flow meter. Peak flow meter is a simple, inexpensive home use tool. It is less, but this peak flow meter is less sensitive and less reliable compared to spirometry. We need to ensure that patient gives the maximum effort, and the normal peak expiratory flow rate does not necessarily mean that there is lack or no airway obstruction. Peak flow meter is advised to be done diurnal during the morning and also in the evening. And then next lung function test is the exercise-induced asthma, where patient will be asked either to run in a certain places or on a treadmill. And then we can measure the FEV1. The FEV1 will decrease during or after the exercise by more than 15%. And the onset of exercise-induced asthma will be within the 15 minutes after a vigorous exercise challenges. And it can resolve spontaneously within 30 to 60 minutes. Next is the radiology test. For radiology, we have the chest radiograph. Chest radiograph is a useful initial diagnosis of bronchial asthma, and it is also available to exclude any other complications like the pneumonia. And most of the time, we can see either it can be the normal or hyperinflated lung. Okay, next is the chest CT scanning. Chest CT scanning is the second line examinations that useful in the patients with chronic or recurring symptoms or those in the complications.
We never do CT scan in asthma patient.
Oh,
Tak pernah buat.
alright. Okay.
Okay.
So moving on to other investigations, we have the fractions of exhaled nitric oxide. It is a non-invasive marker of the airway inflammations, but because it is expensive, it does not being done to the patients, but only being done for study purposes. And then we also have the allergy testing. Basically, it is the skin prick test. It is to identify the allergic factors that may significantly contribute to the asthma. And lastly, we have the histologic findings. For histologic findings, usually we can find the eosinophilic infiltrations, narrowing of the airway luminal, bronchial epithelial denudations, and mucus. And in severe cases, we can see a thickening of the basement membrane and airway remodeling in the form of subepithelial fibrosis and smooth. Lastly, for management in asthma patients, we have there are four management asthma patients, where the first one is the treatment, prevention, assessment and monitoring, and lastly the education. For the treatment, basically it is the medications that given to the asthmatic patients we can divide it into two. Either it is a long-term control medication and also a quick relief medication. For long-term control medications, we have, for example, the first one, we have the inhaled corticosteroid. Inhaled corticosteroid is more effective anti-inflammatory for the chronic and also the persistent asthma. And for example, of the inhaled corticosteroid is the nebulizer solution. Second one, we have the leukotriene modifiers. For the leukotriene modifiers, we have, for example, the zafirlukaz, the montelukaz, and also the leukotriene synthesis inhibitor, the xylitol. Okay, the third one is the long-acting beta-2 agonist. If patients are less than 4 years old, we can give them salmeterol. If patients more than 5 years old, we can give them salmeterol. It is a twice daily dose to relax the airway of the smooth muscle cells. And we have also the theophylline. Theophylline is widely being used previously, but then because of the current treatment is too aiming for the inflammation control of the asthma, therefore it is not so widely being used now, because theophylline is just for mild to moderate bronchodilators. And then lastly, we have the anti-IgE monoclonal antibodies. This, for example, we have the omalizumab. Okay, omalizumab is to prevent the binding of free IgE to receptors on the basophils and also the mast cell. And but then this is only approved for the patients more than 6 years old. And, the relief medications, we have the short-acting energy agitator bronchoconstriction. And lastly, we have the oral corticosteroid. For oral corticosteroid, it is either liquid or tablet formulations. And the prolonged use of oral corticosteroid may lead to cushingoid features, hypertension, diabetes, cataract, glaucoma, and etc. Okay, for the preventions, patients need to know what the trigger factor that cause asthma, and they need to avoid from it. For example, any environmental allergens like the house dust mites from the carpet, or any animal dander, the pollen, or even the cockroaches. And also, patients also avoid from the surroundings of smoking, because the cigarette smoke can irritate their airway and causing asthma. But then patient cannot avoid from doing exercise. But then before they do some exercise, we should advise them to take the beta-2 agonist. And then others, we have the respiratory tract infections and the food allergy. For the assessment of the asthma, we can know the level of asthma control by asking, after initial treatments for about 3 to 6 months after that, we can do some assessment for the asthma to know whether it is a well-controlled, partly controlled, or uncontrolled asthma. Okay, we should ask the patients in the past 4 weeks either there is daytime asthma symptoms, any nocturnal symptoms, or any relievers that need to for the symptoms, and also any activity limitations because of the asthma. From this, we can know either the asthma is a well-controlled, partly controlled, or uncontrolled. And then for monitoring, first we have the assessment like what I've mentioned before. And then we also can monitor the compliance to the asthma therapy, the frequency and the technique that have been done. And also last but not least, we have the asthma educations. For asthma educations, it is basically a self-management education that focus on the teaching the patients about the importance of recognizing their own level of control and also signs of progressively worsening asthma symptoms. So basically that's all from me.
Any questions?
These are my questions.
Any questions? Okay. Next. No questions? No. Okay, next.
I will be the next presenter. Presenting about
Rahimi
bronchiolitis.
Jamil.
Rahimi. Aiman Rahimi.
Huh?
Aiman Rahimi.
Siapa Rahimi Jamil?
Okay.
Aiman Rahimi. Tajuk apa?
Bronchiolitis.
Okay.
Okay. Okay, we start. Bronchiolitis, know is a lower respiratory tract infections that affects the bronchioles with a characteristic of increased mucus secretion production and occasionally will produce bronchospasm and lead to airway obstruction. And it is a common respiratory illness that occurs in a very young children and most commonly in infants between 2 to 6 months old. Respiratory syncytial virus (RSV) is
Syncytial virus. Syncytial virus.
syncytial virus. Syncytial virus is a common cause of bronchiolitis in Malaysia. The epidemiology, as I said before, it is commonly affect the infants and children younger than 2 years old, and the peak incidence of this disease is occur in fall and winter season. In Malaysia, it is endemic throughout the year, and it is have higher prevalence.
Endemic, tapi ada spikes. Dua spikes. One in June, July, and another one at December.
Okay, thank you, Doctor. It is have higher prevalence in urban areas. It is a very important disease because it have high hospitalization in infants and young children. Okay, move on to the etiology. The commonest cause of bronchiolitis is the respiratory syncytial virus (RSV), and followed by the human metapneumovirus, adenovirus, parainfluenza virus, coronavirus, influenza virus, rhinovirus, and mycoplasma pneumonia. The mode of pneumonia. Thank you, Doctor. Mycoplasma pneumonia. The mode transmission of this disease is spread by contact with the infected respiratory secretion, droplets from the cough or sneezing. Okay, the pathogenesis of the bronchiolitis is infants usually love to put their hands to the mouth, and the contaminated hands with the virus may infect the terminal bronchiolar epithelial cell. Bronchiolar epithelial cell and cause damage and inflammation. The inflammation will lead to mucus secretion, edema, necrosis, slaughtered epithelial cell, which can lead to obstruction of the bronchioles and atelectasis. Moving on to the clinical manifestation, the infant first develop a mild upper respiratory infection, for example, coryzal symptom such as nasal discharge and obstruction and mild cough. The infant may present with low grade fever, with decrease in appetite. The disease will gradually progress and infect the lower respiratory tract, and the infants will present with increased breathing rates, wheezing due to obstruction, persistent cough, difficulty in feeding, and might be apnea in infants. On examination, you can see the infants or child will have a sharp or dry cough, tachypnea, subcostal and intercostal recession, tachycardia, cyanosis or pallor, symptom of respiratory distress, nasal flaring, and grunting. On palpation, we can see that the chest is hyperinflated, with the liver is displaced and the sternum become more prominent. On percussion, the chest will have a hyperresonance. On auscultation, we can hear a fine late inspiratory crackles, sound like burning woods, prolonged expiration, and a high pitch wheezing due to obstruction. Okay, here the sign and symptom of bronchiolitis in infants. Moving on, the investigation. So how is bronchiolitis is diagnosed? Clinically, it is diagnosed based on a history and physical examination, diagnosed clinically. Usually imaging and other tests is not usually done or necessary, but can be helped with the diagnosis. For example, for imaging X-ray, we can see the hyperinflation of the chest or segmental or lobar consolidation. Here I have give the X-ray of infant with hyperinflation of chest. You can see the flattening of diaphragm, the increase in hilar bronchial markings, and moreover. Next is the pulse oximetry. It is done to measure and monitor the arterial oxygen saturation because the infant is usually in a very stress condition, shortness of breath and moreover. So we must monitor the oxygen saturation in this child. And blood gas analysis, which only be done in severe bronchiolitis, which to identify hypercarbia, which is the increase in carbon dioxide concentration. For the complication of the bronchiolitis may include dehydration because the obstruction of the airway associated with tachypnea and moreover will make the infant difficult to feeding and may lead to dehydration. And next is recurrent apnea. The bronchiolitis may lead to respiratory failure. Some may lead to asthma and rarely will lead to secondary bacterial infection. For the management, it is a guideline for the hospital admission of viral bronchiolitis. Let's see, there's two, home management and hospital management. The treatment and management of the okay.
Explain lah, oi.
For home management, usually the infant and children is the disease of the bronchiolitis is usually mild. There is no central cyanosis, apnea is not present, and the oxygen saturation based from the oximetry test is more than 95%. And not belong to the high risk group. It means that the infant is not premature birth with normal weight, no neurological symptom or pulmonary or CNS disease. And for hospital management is usually the infant and or children is in a very severe cases.
Okay now.
Okay, the treatment and management for hospital admission of bronchiolitis is mainly supportive. First, the oxygen therapy. We, we must give humidified oxygen which delivered via nasal cannula. It is the concentration oxygen is determined by the pulse oximetry, which must be maintained above 93%. And we must also monitor for any sign of impending respiratory failure. And next is nutrition and fluid therapy. For nasogastric feeding, it is not usually done, but it can be done for children who refuse to feed and also to empty the dilated stomach. And for intravenous fluid, can be done for children with severe respiratory stress, cyanosis, and apnea. And next is nebulized bronchodilators. We can give hypertonic 3% saline solution via nebulizer. It is shown that it can increase the mucus clearance and significantly reduce the hospital stay of among non-severe acute bronchiolitis. Next, we can give inhaled beta-2 agonist, but if we give, we must have regular assessment and should be done to the patient. For antibiotic therapy is not usually done but recommended for infant with certain conditions such as recurrent apnea, possibility of secondary infection or septicemia, acute clinical deterioration, have high white cell count, and progressive infiltrative changes on chest radiography. And others management, it is also not usually done, such as corticosteroid therapy, because it is have no meaningful benefit. Ribavirin therapy also, although it is an approved RSV antiviral agent, but is not registered drug in Malaysia. And chest physiotherapy, which only be done into infant that admitted into intensive care unit, because the chest physiotherapy may cause more harm to the infant than good. And lastly, for the prognosis, most infant in children have mild bronchiolitis, and only a small percent was admitted to the hospital. And most infant will recover from the infection within 2 weeks, and most of the hospitalized infant or children show improvement in 2 to 5 days with the supportive treatment alone. For prevention, monoclonal antibody is given, for example, palivizumab. It is given by intramuscular and monthly. It also shows a reduce in number of hospital admission in high-risk infants. Here, I've included with some to differentiate diagnosis of bronchiolitis, asthma, and pneumonia. You can see here the etiology of disease may be different. For example, bronchiolitis is mainly caused by virus, while
Betul. Etiologi pneumonia for children mainly virus. Betul.
Okay, thank you,
Risk
Doctor.
factor banyak lagi risk factor ini pneumonia ni, immunodeficiency saja, malnutrition and ni faktor fisiologi okey. Okey. History so much physical finding okey. Percussion doesn't much. Bacteria lah. Color consolidation, dah not all long field consolidate.
Okay.
Bronchial bleeding, sometimes they can have wheezing also in bronchial pneumonia, especially ke viral pneumonia. Ada betul, ada tak betul lah.
Okay, I will fix it later.
Okay, ada lagi?
Okay.
I nak tanya, okay, kita just to tell you all, we made a discussion already, you know. Those mana kita orang tak nampak muka kan, macam you all buat macam ni, we consider tak datang tau, right? You faham tak? So dalam apa tu ni, you all muka semua kena nampak tau. I don't know kenapa you all tak nak letak muka you all. And furthermore, you kena faham tau, we all have to recognize you all. Kata dalam exam ke apa ke, we know siapa. Kenapa you all tak nak letak muka you all ni? Apa reason you all? You make us suspicious tau. Tengok lah, nama semua, apa reason you all ni? Fatin, Nurul Sufiana, Halisa, Najihah Supra, apa you all tak nak letak muka you all ni? I beritahu you, it's good for you all if lecturer kenal you all. Tahu, bila dah exam atau apa, kita kenal siapa. Kalau kita tak kenal ni, kita susah nak tolong. We tend to say that, oh tak kenal lah dia ni, tak ni, macam mana dia ni. So we not, tend not to help you all do the exam. Dia tendency pula sekarang nampak you all tak letak muka you all. So I nak semua orang letak tu nampak muka. Kalau tidak, I consider yang tak nampak muka tu tak datang. Because we already discussed about this. So I give you 5 minutes to settle this one. When I come back, I nak semua dalam ni muka 33 of you ada. Okay, come. Okay, what you all notice? You all notice that respiratory disease, asthma, diagnosis mainly by clinical, Clinical. There's no really test dalam investigation to tell you that the child is asthmatic, not asthmatic. All is a clinical. So you show that the important is the clinical scale. So are the bronchiolitis. Bronchiolitis, is there any test that to tell you the child bronchiolitis or not? Tak ada kan? All is by clinical. Clinical will history, physical examination, and your finding is to tell you this is a bronchiolitis or not. Kita balik semula slide tadi, slide yang differentiate between the asthma, pneumonia and bronchiolitis. Aiman. Mana Aiman? You slide yang akhir sekali tu. This one You see you go through the bronchiolitis, asthma, pneumonia. Okay, you see it's all okay. Pneumonia, perhaps you got chest X-ray lah. You can help you determine that. Even asthma doesn't much in chest X-ray, just hyperinflation. Bronchiolitis, nothing. It's just hyperinflation only. And pre-bronchial thickening. That's all. And then the risk factor usually not much difference. You ask me congenital heart disease. They also have the risk having pneumonia. Preterm, they also have the risk of having pneumonia. So it doesn't mean much. Except in asthma, they are more atopy. That's all. More atopy than the two. But child with atopy also have higher risk to have bronchopneumonia. Pathophysiology then is it. Tapi the problem is that when you saw your patient, his child, all of them tachypneic. All of them have can be cyanose. All of them has recession, intercostal recession. All of them, if you auscultate, all of them can have bronchiolitis, wheezing. But some of them got, but the more prominent in asthma. But the rest also can have wheezing. All of them can have capitation. Then you see, can you really differentiate that? That really in a way that then furthermore, investigation, there's no really investigation that differentiate between the bronchiolitis, asthma, and bronchopneumonia. And to tell you, those with asthma also have a high risk having bronchopneumonia. Then those asthmatic child has high risk to having bronchopneumonia than normal child. So bronchiolitis, many of the cases, bronchiolitis, 10-20% of them will develop asthma as secondary. So you see there are many overlapping between this disease. At the end of the day, the most important your clinical skill. Your clocking, your history, your history, physical examination, and then you look at overall, then you have to decide, is it bronchiolitis, asthma, or bronchopneumonia. So next presenter siapa?
I am the next presenter, Doctor.
Any question or not? You topik apa? You topik apa?
Croup and epiglottitis.
This is apa airway? Nama siapa?
Muhammad Afiq Idham.
Mana cari Muhammad?
Afiq Idham.
Idham.
Yes, Idham Ismail.
Muhammad Idham Ismail. Okay.
Okay, can you guys see my slide?
Yes.
Okay. If so, I will start my presentation now. So, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. I am Muhammad Afiq Idham bin Ismail, matric number 1817741. And to continue the seminar presentation for today, I will share with you guys about croup. No. I will share with you guys about croup and epiglottitis.
You all. Betul, I suka buat dekat ni face to face. You all akan pakai lawa-lawa, smart, semua muka berseri datang Ini muka lah sepenuhnya lah, tak usah sikat rambut. Tengok tak sikat rambut. Email mana email? Email? Email dengan Nurul Ain, mana email Nurul Ain?
Ada doktor.
Apa you tak dapat dia punya tu internet dia? Ni lain.
Dia macam slow sikit. Sekejap, saya try.
Email mana?
Email laptop dia problems. Sekejap. Dia kan cuba nak masuk.
Belum ni tak didengar tak? Okey, sambung croup epiglottitis.
Okay, so this is my outlines for my seminar presentation for today. So firstly, we will talk about croup. Okay, croup is also known as laryngotracheobronchitis, and this is actually a result of viral infections that lead to inflammations in the larynx, trachea, and also bronchi. So this croup usually occurs in children in between 6 months until 6 years old, and the most common infectious agent that cause croup in children is parainfluenza virus. And croup in children may also be caused by influenza virus, human metapneumovirus, RSV, adenovirus, enterovirus, measles virus, mumps virus, rhinovirus, and rarely caused by Mycoplasma pneumoniae and Corynebacterium diphtheriae. So for the pathophysiology of croup, as you can see in this picture, when the viral invade the cells in the larynx, trachea, and also bronchi, there will be mucosal inflammations. And these mucosal inflammations will lead to edema. And when there is edema, that means that the tissue in the area is swollen and it will lead to narrowing of the airway. In addition to that, there will be an increase in the secretions. So that is the pathophysiology of the laryngotracheobronchitis or croup. So for clinical features of croup, I would like to tell you guys that actually the signs and symptoms for children with croup are worsened at night and they are aggravated by crying and agitation. However, the sign and symptom for croup will resolve completely within a week. And the children with croup usually precedes with prodromal syndrome such as coryza, low-grade fever, and also rhinorrhea. These are the important signs and symptoms in the children with croup. The first one is barking cough. The next one is voice hoarseness. And when we do auscultation, we can hear harsh rasping respiratory stridor. And also the children will present with signs and symptoms of respiratory distress, such as dyspnea, increased respiratory rate, and also cyanosis. Usually, croup usually diagnosed clinically. However, when we are not sure about the diagnosis, we need to do chest X-ray. So in this picture, the red arrow show dilated hypopharynx, and the white arrow indicate that there is enlarged laryngeal ventricles, and the blue arrow here show that there is stenosis. There is stenosis of the subglottic. So
narrowing of stenosis.
Narrowing of the subglottic. So in the right picture, the commonest features that we can see in the chest X-ray of the children with croup is actually steeple sign. This is because of the narrowing of the subglottic. So these two pictures just to compare between normal chest X-ray in normal children and also chest X-ray in the children with croup. As you can see, there is subglottic narrowing here. Okay, next, let's look at the management, treatment, and complication for croup. So first and foremost, when we receive a children with croup, we need to assess the severity of the patients. The severity can be assessed using Wegener. So this is the assessment for disease severity using Wegener. If the children is stridor when excited or at rest, and they have no respiratory distress, then the children have mild croup. And for moderate croup, it is characterized by stridor even at rest, and also they have intercostal, subcostal, and also sternalization. And for severe croup, it is characterized by stridor even at rest with marked recession, reduced air entry, and also the consciousness level of the children with croup will be altered. So this assessment for the severity.
Go back again. Important this one, stridor during excited only, stridor at rest, and stridor at marked rest. Stridor at rest with marked recession. This is very important. Next.
Okay, basically this assessment or this severity assessment is very important because from this assessment, we can know what treatment that we need to give to the children with croup. After we have finished with assessment of the severity, we need to determine whether the children with croup need to be admitted to the hospital or not. So if the children have moderate to severe croup, less than 6 months old, and have poor oral intake, have toxic ill-looking, and they live far away from the hospital, then they need to be admitted to the hospital. And after that, for the treatment, first thing that we need to treat is to treat the airway. We need to manage the airway first so that the children can breathe properly. And if there is hypoxia, we need to treat the hypoxia. After that, we need to reduce the croup severity by giving the oral dexamethasone, prednisolone, and also nebulized steroid. And if the children have severe croup, then we need to give them nebulized epinephrine and also oxygen face mask. And for the complication of croup in children is bacterial tracheitis, which is the secondary infection after the viral infection. So that's all with croup. Now let's talk about the epiglottitis. So epiglottitis is actually an intense inflammation and swelling of epiglottis and surrounding tissue. It usually occurs in children in age 1 to 6 years old, and it is a life-threatening condition. The causative organisms for epiglottitis is Haemophilus influenza type B. However, this disease is rarely occurring nowadays. Why? Because as we know, the Haemophilus influenza type B vaccine have been introduced into our vaccination program. Therefore, the disease is rarely occurring nowadays. So for the pathophysiology of epiglottitis, as you can see in this picture, when the epiglottis is inflamed, when the epiglottis is infected by the Haemophilus influenza type B, it will inflame. And as we know, inflammation will lead to edema. And as we know that you can see in this picture, the epiglottis is swollen. So when there is the epiglottis is swollen, the airway will become narrowed, and it can cause obstruction in the airway. So this is the clinical features for epiglottitis. In the early stage, the children will have high fever, usually more than 38.5 degrees Celsius, and the children with epiglottitis will have painful sore throat, and this painful sore throat will eventually lead to dysphagia. And after that, the children will have ill toxic looking. And in the progressive stage, the children will have dysphagia, which is difficulty in swallowing, because there is difficulty in swallowing. So when there is difficulty in swallowing, the children is not able to swallow their saliva. Therefore, there will presentation of saliva drooling. The children also will have respiratory obstruction because of the swollen epiglottis itself, and these respiratory obstructions may lead to the presentation of the signs and symptoms of respiratory distress in the children with epiglottitis. The children also will have dyspnea, and also the children are more prone to sit in tripod positions in the progressive stage. And for the late stage, the children will have soft inspiratory stridor. This can be heard when we do the auscultation on the patient. The patient also will become cyanosis because of the respiratory distress, and the patient may develop concomitant bacteremia. So this is actually the tripod position. This tripod position is very crucial for the children because they will sit in this position if they have epiglottitis. Why? Because they need to maintain their airway. So as you can see in this picture, the children have hyperextended neck, and the children is straight. They sit straight upward, and they lean forward. And also you can see the mouth is open, the chin is up, and also you can see bracing on the arms. So this position is very important for the children because they need to maintain their airway. Okay, next for investigation of epiglottitis, to diagnose for investigation of epiglottitis, we should do chest X-ray, and as you can see in the chest X-ray picture, this arrow indicate the thumb sign. So basically, this thumb sign is for we can see that there is actually a swollen epiglottis. And this in the laryngoscopy, as you can see, this is epiglottis, a large size of epiglottis, swollen and cherry red in color. Chest X-ray and also laryngoscopy. So for management, treatment and complication, I would like to remind you guys that epiglottitis is actually a severe condition, and they need urgent hospital admission. So the first thing we need to do is we need to secure the airway. So we should do tracheostomy by endotracheal or nasotracheal intubation, and this can be removed after 24 hours. After that, we need to take the blood samples. This blood sample is actually for culture and sensitivity purposes. And also, we need to give them treatment, antibiotic treatment, and this is given intravenously for 3 to 5 days. And after that, they will recover within 2 to 3 weeks. Okay, for the complication of epiglottitis, the children will develop pulmonary edema because of acute airway obstruction, and also pneumonia because of concomitant bacteremia. Okay, this is the differences between croup and epiglottitis. As you can see here, the children with croup will have onset over days. However, when the children have epiglottitis, the onset is only over hours. The children with croup may proceed with coryza. However, in epiglottitis, the children does not proceed with coryza. The children in croup have severe and barking cough. However, cough is absent in epiglottitis. The children with croup may not present with dysphagia, so they're able to drink properly and there is no drooling saliva. However, in epiglottitis, the children may develop dysphagia, and this will lead the children to not able to drink properly, and also the children will have drooling saliva because they cannot swallow their saliva. And also the children will with croup have unwell appearance, and the children with epiglottitis have toxic ill appearance. And when we do auscultation for the children with croup, we can hear harsh rasping stridor. However, in the children with epiglottitis, the stridor is soft whispering stridor. And in the children with croup, there will be voice hoarseness. And in the children with epiglottitis, they will muffle and reluctant to speak. So this is my references. I think that's all from me.
Okay, good. Any questions? Any questions?
I have a question. What is coryza?
Coryza sesama lah, air hidung berair.
Thank you, Doctor.
Sesama coryza. Okay, anything else? Okay, siapa next speaker? Topik apa?
Me, Dato. Saya, Dato.
Muhammad Zul. Topik.
Topik pneumonia.
Okay. Pneumonia, okay.
Let me share my screen. Assalamualaikum warahmatullahi wabarakatuh. My name is Muhammad Zulfahan bin Zakaria. Will present childhood pneumonia. Okay, this is my content of presentation. Start with definition, and then with the epidemiology, risk factor, etiology.
Wow. Okay.
Etiology,
pathogenesis,
classification, clinical manifestation.
Classification lah.
Sorry.
Classification. Okay,
clinical manifestation, investigation, principle of management, complication, and prognosis.
Okay.
Okay. What is pneumonia? Pneumonia is an infection of the lower respiratory tract that involve the airways and parenchyma with consolidation of alveolar spaces. And for the epidemiology, pneumonia is the leading causes of death globally among children younger than age 5 years, that accounting for an estimated 1.2 million, about 80% total death annually. And the incidence of pneumonia is more than tenfold higher, and the number of childhood-related death for pneumonia is about 2,000-fold higher in developing countries than the developed countries. And then this is to show that this is a statistic of disease, statistic of cause of death of Malaysia 2015, 2016. And as you can see, in infant death, it is the third common death, which is about 3.9% causes of death in infant death. As you can see, the what we call the trending cause of death in pneumonia is lower. And next is a risk factor of the pneumonia. Risk factor pneumonia is a low birth weight and low weight of for age, malnutrition, lack of breastfeeding, a failure to complete immunization, where as we know that what we call the children must complete the immunizations, especially in Haemophilus influenza type B and others immunization. The children is living in overcrowding place, or there is a poor environmental factors, such as where the children exposed to tobacco smoke, contact illness, and inhale the pollutant, and others like immunosuppression, immunosystem disorder, and lung disease such as cystic fibrosis, asthma, bronchopulmonary, and pulmonary dysplasia. And then this etiology of the pneumonia. Pneumonia caused by microorganism infection like bacteria. The common bacteria that can cause pneumonia, such as Streptococcus pneumoniae, group A Streptococcus, group B Streptococcus, and other like that can cause atypical pneumonia like Chlamydia trachomatis and Mycoplasma pneumoniae, and uncommon like Haemophilus influenza type B because of the immunization cycle. And like virus, the common causes of the pneumonia is respiratory syncytial virus, para-influenza virus type 1 to 3, influenza A and B, and adenovirus. Like fungal, parasitic, and mycobacterial infection is uncommon, but there is the list what we call the agents that can cause the pneumonia. And then we can also divide it into age group that pathogen for the pathogen for pneumonia, such as like newborn, the common bacteria that cause pneumonia in newborn, like group B Streptococcus, and infant 1 to 3 months like Chlamydia trachomatis, preschool age like Streptococcus pneumoniae, and the school age the Mycoplasma pneumoniae and Chlamydia pneumoniae. And then the pathogenesis of pneumonia, as we know, the lower respiratory tract is is a sterile place, which means uh, our body has a mechanism to defend from defend the lower respiratory tract from the infection. Pneumonia occur because there is a factor like defect in host defense and evasion by violent organism. And how pneumonia can happen? Pneumonia can happen when there is a infection to the lung, like bacteria and virus, that lead to inflammatory response initiated and lead to alveolar edema plus with the exudate formation, and then the alveolar and respiratory bronchioles will fill with serous exudate blood cell, fibrin and bacteria, and then lead to a consolidation of lung tissue. And then how we can classify pneumonia? For the first one, the location and anatomical classification, where there is three, which are bronchopneumonia, lobar pneumonia, and interstitial pneumonitis. The first one, bronchopneumonia, is inflammation of the tract is centered in the bronchioles and lead to the production of mucopurulent exudate that can obstruct the airway and cause patchy consolidation of adjacent lobules, like that affect the what you call the bronchioles. And then lobar pneumonia, the pneumonia is localized to one or more lobes of the lung. And the interstitial pneumonitis is inflammation of the interstitium, where the wall of alveolar sac and duct of alveolar sac and duct and the bronchioles. And then other classification like the etiology of the causes of pneumonia itself, like microorganism like bacteria, viral, fungal, just like the etiology and how it's acquired. Like community acquired, which means that community acquired is in the pneumonia occur in the population, like a public population. And nosocomial acquired, that pneumonia that happen in the hospital, like it can caused by Staphylococcus aureus. And the clinical manifestation, the patient will have high fever, productive cough, tachypnea, and respiratory distress that can characteristic by tachypnea, hypoxemia, increased rate of breathing, intercostal, subcostal, suprasternal retraction, nasal flaring, grunting, and accessory muscle use. The patient with pneumonia also can have chest pain and a poor feeding. And this tachypnea is defined as follow in child under 2 months age. The what we call respiratory rate above 60 per minute is considered tachypnea. 2 to 12 month age children above 15 per minute respiratory rate, and 12 month to 5 year age tachypnea is considered 14 per minute respiratory rate, and 5 children with 5 year above is follow the adult respiratory rate, which is 20 per minute. And this is a picture diagram show the chest indrawing, where when the child is inhale, there is like a groove on the chest, and this is a nasal flaring where the nose become become larger. And then in respiratory examination, on the chest movement, there is a reduce on affected size, and there is a rapid shallow breathing. On percussion, there is a dull percussion and increase vocal parameters. On auscultation, you can hear a crackle sound and a bongo sound.
Crackle tu apa?
Crackers is like
Crackle to a US definition. Ni for capitation.
capitation.
Kita pakai apa?
What?
Ha?
Capitation.
Kita Malaysia kita pakai apa? Kita tak pakai crackles dekat Malaysia. Kita pakai apa?
Capitation.
Ha? Ha?
Capitation.
Capitation. Tulis capitation, apa tulis crackles. Ni you copy you download lecture orang ke lecture you ni? Ha? Campur. Tak pandai. Sebab kalau you tulis lecture you sendiri akan tulis ni capitation. Continue lah.
And in investigation, we can do just radiography where there is a indicate when clinical criteria such as pneumonia, and the chest radiography does not differentiate etiological agent, and then we must do a white blood cell count where there is an increased count with predominance of polymorphonuclear cell that suggest bacterial causes, and increase of lymphocytes suggest viral causes or overwhelming infection. We can also do the blood culture where it is a non-invasive gold standard for determining the disease etiology, but the sensitive is low, about 10% to 30%, and we must consider doing the blood culture in children with severe pneumonia or the children not respond to the first line antibiotic, because we can also do the pleural analysis and because of the pleural effusion.
If there is pleural effusion, kita tak payah.
And then lastly, we can do the serological test where it should be considered for children aged 5 years or older, and when we suspected atypical pneumonia. And this is a diagram that show the chest X-ray of the patient with pneumonia. And then for the principal management, first we must assess the severity of the pneumonia. For the age under 2 months, the severe pneumonia, the patient must be considered as severe pneumonia where there is a severe chest indwelling and tachypnea, where in very severe pneumonia where the patient is not feeding, convulsion, abnormally sleepy or difficult to wake, or the patient have a fever or hypothermia. For the age 2 months until 5 years, the patient with tachypnea is considered as a mild pneumonia, or where the severe pneumonia there is a chest indwelling. For the very severe pneumonia, there is not able to drink, convulsion, drowsiness, and malnutrition. We must do the assessment of oxygenation with the objective measurement of hypoxia by pulse oximetry. And then this is a criteria for hospitalization, where if the patient have community acquired pneumonia, it can be treated at home by giving the antibiotic. And indicator for hospitalization, which are children aged 3 months and below, fever higher than 38.5 degrees Celsius, with refusal to feed and symptom of vomiting. Patient with fast breathing with or without cyanosis. There is associated systemic manifestation. Patient with failure of previous antibiotic therapy, recurrent pneumonia, and severe underlying disorder like immunodeficiency. And this is the list of antibiotic for the for the bacterial pathogen and recommended antibacterial agents. For example, like pathogen for the beta-lactam susceptible, like Streptococcus pneumonia, we give penicillin and cephalosporin. Hemophilus influenzae B, we give ampicillin, chloramphenicol, or cephalosporin. And like other organism, like Mycoplasma pneumonia, chlamydia, and Bordetella pertussis, we give mycolides, for example, azithromycin. And for the management of the inpatient, we give antibiotic for the first line. We give the beta-lactam like benzyl, penicillin, moxicillin, ampicillin, amoxicillin, and clavulanic. If when we assess, when we follow up the patient does not improve, we give the second line. We give second line antibiotic like cephalosporin, ceforazimide, ceftazimide. And then the other agents like aminoglycoside for the atypical pneumonia. And then we do the suppletive treatment, like we give the fluid. In pneumonia, dehydration is not common, so we must careful and we give rehydration to avoid over rehydration. And oxygen, we give the oxygen therapy so that the oxygen can achieve about above the 95%. We can give a cough medication, but it got
cough medication we rarely give lah. Physio, chest physio, yes. Okay, huh?
Okay. Temperature control and self physiology, where we physiology. And then for the outpatient management, in children with mild pneumonia, where they are breathing fast but not just enduring, we not consider for the hospitalization, and oral antibiotic can be prescribed for the patient, and we must educate parents or caregiver about management of fever and preventing dehydration, and educate patient to identify the signs of deterioration. And the child should return in 2 days for reassessment or earlier if the condition is getting worse. And the prognosis of pneumonia, Patients with uncomplicated bacterial pneumonia should respond to therapy. Improvement in clinical symptoms within 48 to 96 hours. And radiographic evidence of improvement lags substantially behind clinical improvement. And if the patient is not improved, there is some possibility that when a patient does not improve, such as there is a complication, bacteria resistant, and non-bacterial etiologies that can cause pneumonia, and bacterial obstruction, pre-existing disease, and other non-infectious causes. And the complication of the pneumonia, it can lead to parapneumonic effusion, and if the pleural effusion is contained in the pus, it leads to a lung emphysema, and then it leads to the scarring, which is bronchiectasis, and then lastly, it can lead to
bronchiectasis.
And lastly, it can lead to the accumulation of the pneumonia, can lead to lung abscess. And I say this is my reference.
Any questions? This to the bronchiolitis, asthma, and pneumonia will be the lower airway. The upper airway will be the Crohn's and epiglottitis. This is upper airway. The landmark of the upper airway, lower airway is the thoracic inlets. This one, anything above the thoracic inlet is upper airway, anything below thoracic inlet is a lower airway. So basically, okay lah, you cover almost the common things lah. Okay, any questions? Any questions? Tak ada questions. Weekend. Sepatutnya apa? Weekend ni tidur relax, kena belajar. Siannya lah. Tapi tak fikir kita orang sepatutnya hari ni kata relax dengan anak tapi tu saya ambil you all sebab 2-3 hari seminggu ni penuh, especially habis exam, you punya senior exam. Lagi banyak you all ni semalam tak ada apa, petang semalam. Yang betul yang procedure tu your group juga ke year 5? Procedure tadi kan your group tak ada kan?
SOP ke yang exam?
Procedure presentation procedure.
Oh bukan.
Bukan Nak bilang apa mata bengkak tu. Yalah. Kita buat 8 pagi lain kali tak? 7 pagi. Semua bangun awal sikit tak? Lepas subuh kita buat. You nak tak lepas subuh buat terus? Tak bangun lagi. Any questions?
Datuk nak tanya. Yang untuk session hari Isnin pukul 2 petang pasal tropical infection.
Cuba lewat sikit lah. Nanti kita beritahu bila.
Bagi tahu nanti
Tapi lewat sikit nanti beritahu bila.
Hari sama tapi lewat sikit, okay.
Nanti beritahu bila. Sebab aku kena check jadual.
Thank you, Datuk.
Rasa lewat sikit. Tak apa. Anything else?
Selain itu yang tadi Datuk ada mention yang pasal apa tu crepitation dengan crackers. Apa lagi yang
itu je lah. Tapi we know lah kalau crackers tu you download daripada US punya lecture. US pakai crackers, kita pakai crepitation.
Okay.
Crackers. Itulah you orang lucu ketangkap kan. Tak smart kan. You tahulah sebab you go anywhere in Malaysia, kita tak pakai crackers, kita pakai capitation. Okay, ni ada question. Okay, habis. Nanti jumpa petang Jumaat, petang Isnin. Okay. Okay, finish.
Okay. Thank you, Datuk.
Thank you, Datuk.
Thank you, Doktor.
Thank you, Doktor.
Thank you, Doktor.
Yeah.